everyone. Welcome back to Optometry Unleashed. I'm Dr. Trevor Miranda. Today, we're talking with Dr. Cameron McCroden. He's one of Canada's leading voices in vision therapy and neuro-optometry, and an innovator who's been changing the way we think about concussion care. He's also the author of Optimize and the founder of neurovisualtrainer.com, a platform that's making therapy more engaging and accessible for clinics and patients alike. Cam, I'm really excited to dive into this conversation with you. Welcome to the show.
Awesome. Thanks, Trevor. I'm happy to be here. I've watched you and looked up to you for years too, so it's an honor to be part of it.
Thanks, Cam. I want to talk about your pathway into optometry because it wasn't exactly conventional. What drew you into vision therapy and neuro-optometry rather than primary eye care?
I think starting at the beginning with that, I mean, I grew up wanting to be an engineer. That's what I was dead certain I was going to be. Go into engineering. I wanted to invent things that would help people. And quite frankly, my first year of engineering at UVic, something felt like it didn't fit. I wanted to work more with people, and I was worried I was going to get stuck working up in Fort Mac. That just didn't really feel right. So leaving that, I think my parents had a panic. Imagine your kid calling you and all of a sudden they're like, I don't want to do my degree anymore. And, I might take a year off and go to South Africa. Um, so, and that was way back when too. Heading back into university, one of the things my dad made me do, which was really bright, was he had me go and interview a bunch of different people in different professions. So, go speak to a lawyer, go speak to an MD, go speak to, this type of surgeon, go speak to a dentist. And quite frankly, one of the things that made me pick optometry was I was like, great, I don't want to have to be on call. It's something in, kind of like a health profession where I'm not on call. The optometrists seem to be quite happy with what they do. With I've met, they've got a nice work-life balance and all these other things, and they're seeing people all day. So that was what took me into optometry. So, I got myself into Waterloo, went to optometry school through in Waterloo. I wasn't really super interested in vision therapy stuff in there. Everybody kind of poo-pooed all the binocular vision components. It was it was taught with complete apathy, so that probably didn't help either. And so I kind of came out of Waterloo really thinking for the most part like, oh, vision therapy is kind of quackery. Now, Patrick Quaid, who's, like one of the originals for that, he did get me interested in it in my last year when I met a guy in his chair who was like, I used to think I was stupid because I didn't like to read. And this was a guy in his 50s and like he's like in tears. And now he could read. So there was some interest peaked there, but it was this crazy balance between being told it's quackery and seeing this other stuff and trying to figure that out. Then I came back to Victoria practicing, and I really found like primary care just really didn't feel like it was for me. I, it was missing something for me. So funny enough, I was actually looking at going to go back to dental school because my sister just finished dental school. She's up working in the north, like printing money, and I'm like, well, you know what? If I'm not going to like my job, I'm going to make way more money not liking my job, and then then I can work 3 days a week or retire earlier or do whatever. And one of the guys at the BCDO conference had said to me, "Is like, you should really go down and take these courses." And it was OEP stuff at the time. So I got into that. And very quickly, when I was down there, all of a sudden it kind of occurred to me, I was like, this is like the engineering of our vision. This has to do with like the systems of how our brain's actually processing our vision and controlling our eyes. And then it also struck me that my other sister had had some eye tracking problems all through school. So that had never been addressed at any eye exam. And then I actually learned of my own vision issues, which is, why I was the first one out of every test and I couldn't focus for more than a few pages. So that's sort of where the personal tie came in. So that's sort of the long story short of what kind of got me around to going like, hey, I need to learn more about this area.
Yeah, a few things to unpack there. One, boy, if you said to your parents that you're gonna quit engineering and then quit optometry and go to dentistry, they'd be like, "Whoa, Cam, whoa, get a job. Just get a job." That's kind of what I say to my kids: "Get a job, please."
They'd probably tell me it wasn't the profession that was the problem at that point.
Yeah, 100%, 100%. I know when I went to Waterloo as well, I had the same idea. It was like binocular vision was not my favorite course. I couldn't focus. It's complicated to follow along. It didn't seem practically applicable at the time because we were just talking about brain and eye and turn strabismus and amblyopia and different pieces there, but it didn't seem to pertain to particularly clinical care if we didn't have exposure to that, which I did not. And we have a vision therapy clinic in at Couch and Eye Care, but I know a lot of my colleagues, they're skeptical about vision therapy. It hasn't been universally embraced, especially when we started, Cam. When you graduated, you were sort of one of a kind. So I just wondered, what are some of the common myths you've encountered as you sort of started this process of creating a vision therapy, a neuro-optometry specialty clinic?
Great question. It's always funny. I say this to my patients. When you turn to Dr. Google or you go look at the position papers or other things, you're going to read one of two things. Vision therapy changed my life, or vision therapy is complete quackery, voodoo, and a waste of money. And, and I say to them, the problem is they're both right. And one of the issues plaguing vision therapy and in the area is a misunderstanding of what is it actually and what are you doing and trying to do, a misapplication of it in cases where that's not actually the issue, it's not warranted, etc. Um, those are probably two of the bigger problems. I mean, not to mention, lack of funding for studies and research to some degree because there's nothing patentable. So trying to recoup an investment on doing that's actually very, very difficult. Plus, there's certain types of studies that are not made for therapeutic intervention the same way they are made for pharmacological intervention. But that's a whole other argument. If you had the money, you could show it too. But again, it comes down to methodology. So I think one of the problems I encountered is even under the educational bodies that teach about vision therapy, everybody often seems to be in their own little silo. And so the older approach to thinking about vision therapy is thinking about training the eye, strengthening the eyes, things like that. Whereas what I've come to understand over the last 15 years is really when you're doing anything that way, you're not strengthening eye muscles, you're not changing eye muscles, you're not changing the physical eye. Really, what you're doing is setting up a feedback loop for the brain to learn how to do a certain thing more accurately and more efficiently. Now, that's only effective in terms of treatment if part of the person's problem is that they don't do that thing accurately and efficiently. So, if a kid struggles with reading and they have a massive issue with saccades and binocular function, and you fix those things and then those work better when they're reading, it doesn't matter whether the kid has dyslexia or not, they're going to have an easier time reading because they don't have those issues on top of it. But if you try to teach a kid who has struggles with reading, if you try to give them binocular vision treatment for whatever, but that's not actually part of their problem, it's going to be useless. And so there's a few things in there that end up creating a lot of controversy within it. And then some of it comes down to sort of the model of vision people subscribe to and a few other things along those lines.
Yeah, I wondered. I always thought it would be really interesting to have someone like you, Cameron, to go to schools and train kids that are about to learn to read to really utilize their eyes appropriately before they embark in actually comprehension of reading. What are your thoughts about that?
To be honest, that's one of the legacies I want to leave. I would actually like to see things in a place where that's just considered part of like core curriculum for kids before they read. You know, like before kids are playing soccer, let's make sure that physically they have the capabilities to play soccer. They're not going out there with a broken leg. We shouldn't expect kids to learn to read if they can't make the proper saccadic eye movements to read. If their binocular vision's such a mess that, when they look at a word, each eye is hitting different parts of the same word, not enough to cause true double vision, but enough to confuse them about what they're seeing in what order, they're going to have difficulty recognizing words. So absolutely. There's a lot of fundamentals to almost like a visual fitness, so to speak, that should be part of the educational curriculum.
We're going to take a quick break and hear from our sponsors. I'm thrilled to share an exciting new resource for professionals in the eye health industry. Eye Care Collective. Eye Care Collective is redefining collaboration and growth in our industry. Whether you're a clinic owner, optician, or an eye care professional, this platform empowers you with the tools you need to streamline your operations and elevate your success. As a member, you'll enjoy the benefits of consolidated billing, access to competitive pre-negotiated discounts, and programs tailored to support the unique needs of your practice. If you're ready to amplify your impact in the world of eye care, visit www.eyecarecollective.ca and find out how Eye Care Collective can support your journey to success. You probably do a good job of capturing contact lens sales after seeing a patient. But what happens when they use up their initial supply? Yes, your patients love you, but at refill time, They're probably just taking the path of least resistance to restock their lenses, going online or to the big box stores. These missed opportunities add up to tens of thousands of dollars leaking out of your business. That's where Auto comes in. Auto allows you to be that path of least resistance. Auto is the easiest way for eye care practices to stay engaged with patients and offer them a frictionless way to order their contact lenses and dry eye products from you, rather than from your competitors. Timely refill reminders and one-click reorders offer patients an unbeatable purchasing experience. And on the back end, Auto is integrated directly with your suppliers to allow for uber-efficient order management and fulfillment, saving valuable staff time. Over 600 clinics across Canada and the US are already using Auto to reclaim lost sales and simplify their workflow. Want to learn more? Check out their website at autooptics.io. That's OTTO optics.io. Sell more, do less with Auto. I 100% agree. I mean, we work on so many things, and I think sports and athletes, high-level athletes, I'm sure Sidney Crosby and Connor McDavid and a lot of soccer players, they're embarking on vision therapy for sports vision.
And you know what the crazy part is? We're actually seeing other professions do more of it than optometry. So, a lot of the functional neurology chiropractors and stuff, they're including some of the vision therapy work into their work, which is greatly effective. A lot of the vestibular physios and concussion physios are including vision therapy work into their work. And it's funny because it's like the visual community of optometry and ophthalmology are sort of the last ones to the table there. And it's funny coming from me because I'm one of the world's biggest skeptics. Like there's the old joke in engineering, you know it, Trev, like where your worst patient's the engineer. Like everyone cringes when they've got an engineer in their chair half the time because you know that person's not going to be happy until they know how the thing works and and you've been able to explain it into a way that they buy into it.
Yeah, 100%. I think it's really important for optometry to embrace this eye-brain connection and training that right away. And sometimes I think, I don't know what you think about this, Cam, sometimes a little jealousies in our profession where there's not a collaborative mindset where, let's say you're doing vision therapy and I have a practice that doesn't do vision therapy. Well, I would refer to the expert in that area. If I'm doing dry eye and you're not doing dry eye, you would send patients to me. So that sort of, there's so many subspecialties in optometry right now. You can't be the expert at all of them for sure. And if you're an expert at more than one, well, kudos to you because that's a lot of learning and a lot of keeping up with it. And so I'm lucky enough to be in a group practice, multiple clinics. So we have practitioners that specialize in certain areas. And for sure, I'm not the specialist in vision therapy or binocular vision. But what are your thoughts about that as, being more collaborative with our colleagues on referrals?
You say it very well, and it's amazing that you have the practice you do with the people you have, because I think one of the challenges is that, it's kind of the scarcity and the abundance mindset for things too. When people are really coming at things from a scarcity mindset, they think about losing their patient and, losing their optical sale and losing their thing, as opposed to what comes back around when that patient is so grateful that they were sent to the right place to get that stuff, or when that other professional then sends those types of patients back to them as well. And I don't know if that's bred into us at school at times in terms of pitting people against each other from a competition standpoint. I don't know if that's a scarcity mindset within the profession. I also don't know if that's an ego thing within the profession too, because optometrists tend to have I'm looking almost like an inferiority complex sometimes within the eye care world as well. So it might come from within that. But you're absolutely right. There's so many areas that hopefully the pressure on our colleges will allow us to kind of be able to have subspecialties, but people need to refer within those when it's there. Like I haven't looked at a retina and like, well, actually, maybe I've looked at one or two, but I literally tell people, I'm not the person you want looking for glaucoma, diabetes, dealing with ocular health stuff. That is other people.
Yeah, 100%, 100%. What would you say? it was a breakthrough case in your VT practice that sort of changed how you approach therapy. Was there any particular patient that comes to mind that made you change what you do?
There's actually been a lot. So basically, one of my clinic policies, Trev, has been when we suggest a vision therapy program for somebody to treat something, if our treatment's not successful, generally one of two things happens. Either A, I will keep working at it without any extra charge to figure out why it wasn't successful and get us to that endpoint, which 98% of the time we do, or we will issue the person a refund because that's how we back up our clinical opinion and what we do. But what that often leads to is a lot of discoveries and things because I'm getting the opportunity to troubleshoot these things that you might not have otherwise if that person had to continue paying for a visit and then just decided to stop coming. And and it's also led to me even subsidizing the cost of lenses and glasses myself, which I've looked at as an R&D expenditure. And I'd say one of the fundamental things is it's taught me, number one, how important the proper corrective lenses are within these things. And I just hosted a course for a bunch of physios on the weekend looking at post-concussion and vestibular rehab and the difference the proper glasses lenses can make in those areas, whether we're talking about screen sensitivity, light sensitivity, dizziness, and other things. And that was emphasized to me quite a few times through the course of treatment. Another big one was that it's not about muscles and it's not about training the muscles. It's about using the human attentional mechanism to change what you're paying attention to because like our brain can only process so much of the information that's there. And if you can train the brain to put more attention onto the proper visual cues, you can change the efficiency or accuracy with which somebody does something, and then they can pattern that as the default way to do it. And those were probably two of the biggest changes in my practice, which made a world of difference in outcomes.
Yeah, that's awesome. And I think you really understand the eye brain, and there's a lot of emotions that go into it. Like we see some kids that they feel labeled, they feel stupid, they've almost given up trying because they've gone too long with this binocular vision disorder. And so, how do you unpack the emotions? We see that in dry eye too. A lot of sadness, if you will, or a lot of feeling uh, low and small and not able to be included in things, such as learning how to read. How do you unpack the emotional side to VT?
Huh. It's a good question. I'd say one of the biggest ones for a lot of people, at least at their initial appointment, is feeling heard and validated. If you can put a lens in front of that person's eye that all of a sudden they can see and feel firsthand that their dizziness is less, it's like, don't tell me, show me. And so the validation is often a huge part for people. And then it kind of goes from there. And you'll watch things just sort of naturally change as people go through stuff. But you're right. There's a lot of people that you see where we see adults where a lot of stuff comes up as they go through it because they relive stuff from their childhood in terms of like things that were difficult. Kids, you'd often just kind of watch their confidence change as things get easier for them and they see themselves as somebody who can do things and can learn, as opposed to seeing themselves as, the kid in the class that can't learn.
Yeah, 100%. You give them a little bit of optimism or hope that things can be better and they can really run with that. So that's really cool. I want to talk a little bit about concussions. It's so interesting. And I think, when one of my daughters who's a professional soccer player had a concussion, I think I might have contacted you, Cam, but there's a lot of amazing help there for patients that have concussions. I think it's underserviced in optometry. Like a lot of my colleagues don't even realize that you have so many patients that have concussions that could be really helped, and a lot of them are living with these post-concussion symptoms. Can you first explain to me what happens in some of these patients that have symptoms after a concussion? What's going on there physiologically?
Yep. And it's happened to my family, so like firsthand. So a lot of the time, I mean, when we get a head injury, it can disrupt the connections in the brain at like an axonal level that are it's like the connections that control the software of how we use our eyes, control our eyes, and process the incoming information. And to get really nerdy for a second, the crazy part about our visual feedback loop is that your processing of the incoming information will change how you control your eyes. And how you control your eyes will change your processing of the incoming information. So, for example, if you're looking at things at distance and you tend to have a slight esophoria, that's often an indicator that you do judge things to be closer to you than they are. When it comes to concussion and those things are disrupted, a lot of those patients are displaying poor binocular fusion. They might have something really obvious like a convergence insufficiency or ocular motor dysfunction or, new vertical phoria from a physical injury there, but a lot of them also have poor binocular fusion. The challenge is that you're not necessarily going to register this when you're looking at things from a classic, you know, just kind of refractive error standpoint. And a lot of those times, people are often given almost like false all clears from the visual side of things when they could be helped more. Now, Trev, one of the hardest things that I had to come across, and I only had 2 or 3 years of practice maybe 2 years of practice once I started getting into this area, but I can't tell you how many patients encounters I remembered where I knew now that I failed that person. So as soon as I realized that, okay, a lot of the screen sensitivity stuff people are facing after concussion can be helped with the right lens. And, eye tracking issues can't be treated this way. And I think of the people that I told it was all clear and everything else. And I think that's actually a hard thing when it comes to our colleagues and for people to start changing how they think about something. The very act of doing it differently now means that you also have to make peace with the fact that you have not done it optimally for X amount of time. And they show that with people with age. We get more hardened in our opinions and hardened in our stuff, and people's views are less likely to change because I think it's harder for people to admit that they, could have been doing it better.
Yeah, it's sort of the Dunning-Kruger effect to some
Yeah.
degree.
Yes,
I
exactly.
Yeah, it's so fascinating. I think again that speaks to a little bit of ego, right? And the fact that we have to be kind to ourselves because the science evolves. It's like patients that had macular degeneration went blind and we couldn't do anything about it because we literally didn't know what we could do. We didn't have mitochondrial enhancers and other things that we trying to attempt to reduce the vision loss from macular degeneration that we have now. So same thing, science evolves. Our knowledge, body of knowledge evolves. I think what's really important though is that we literally don't have on blinders, pardon the pun, as optometrists. So we're learning from each other and we're able, at the end of the day, I always say we have an N of one, Cam. We have that
Yep.
patient who's in front of us, right? That patient's the most important patient that we have. And if we can help them, and if that means vision therapy, if that means, a specific type of lens or a filtered lens or whatever it means, let's try to expose that patient to the opportunity to get help. If we're not the ones to provide the help, let's give them resources to find help.
Trev, I love that you highlight that. And I think it applies to ocular health as much as it does to any of the other visual components. So much of what we're taught at school is what's your chief complaint? Do the stuff, do the tests. What are the numbers from the tests? That has so little to do with what that person's actual experience is, what their problems are, and where the opportunities are. You know, you could have one person where they have let's take binocular vision as the issue. You could have one, or even dry eye. You could have one person who lives in an environment and does stuff, and their dry eye doesn't really bother them that much, but you're measuring it the same. Versus the other person where guess what? Their dry eye is ruining every single date night that they go on, and it's a major cause of problem in their life. And I think sometimes we're not taught to take into account the the problems that things can cause in that person's life beyond just the quantitative measurements that we measure through optometric testing.
I think it's true. Both are valid, right? You want a quantitative analysis, so you want to see where they are. What's the baseline? Do they have, for instance, in dry eye, do they have meibomian gland dysfunction? Do they have overt inflammation of the cornea? But the symptoms are so important, and that's when it comes to BV to me. Are you dizzy? Are are you seeing double?
Yeah.
Things like that where we haven't asked those questions as much. I always think neck pain too. Neck pain and other aspects of your wellness is often related to, let's call it a binocular vision dysfunction, if you will. And so there's a lot of those areas that we haven't just inquired before. And then all of a sudden, when you start asking it, you realize there's a lot of patients there that could use some help. It's the same with looking at the eyelashes for blepharitis. A lot of people have blepharitis. You just don't look for it because they aren't complaining about it or you haven't unpacked it. So I think it's really interesting quantitatively and subjectively, unpacking what opportunity there is to help our patient.
And from the binocular vision world of things and the neuro-optometry side, also the qualitative part. There's a big difference between, can somebody do a near point of convergence and it's comfortable versus can they do it and like it triggers dizziness and other symptoms. And if all you're thinking about is what's the distance they get to over one try, you're really missing a lot of the picture. It's the same way, you could measure a certain amount of, like, this is also one of the problems is that depending on how healthy someone's vestibular system is or not, or other things going on, you could measure the same amount of a fixation disparity or aphoria with one person, and they have no real symptoms in day to day life. You could measure the same amount with somebody else, and to their system, that's a big problem, and they're very symptomatic. And so there's something to be said too for even the same measurements kind of applying differently based on the person. But you're right, the objective measurements really guide as to whether or not you have opportunity to help them clinically, but it doesn't necessarily, the size of the measured issue doesn't always correspond directly to the size of the symptom or the size of the problem in their life.
That's so fascinating and so true. It depends. Some people can, let's say, manage their binocular vision exophoria or esophoria or what have you, and other people with small amounts really struggle symptomatically. So that's really interesting. And the other really interesting thing is optometrists like me were taught, to measure your horizontal deviation separately from your vertical deviation. And of course, you and I know this is a pulley system and it varies the amount of effort you need to fixate a target depending on what distance you're looking at. It's more of a dynamic system that includes, horizontal and vertical components of that.
And then also whether you're looking at something in real space or whether you're looking at something in virtual reality or whether you're looking at something in a phoropter will then impact the conscious motor control of what you're doing as well. So it's not this passive system that we really think it is. Even when you're refracting somebody, there's a control component to that also. It's not just the eye isn't just, it's not just like measuring a shoe size.
Yeah, and I think there's more optometrists that are starting to be more functional optometrists. And in fact, I don't even know 100% what that means, where they're refracting a little bit differently based on these other aspects of their muscle misalignments.
I mean, the thing that I'd love to see at some point is that I think there is the room for within every primary care exam to hit on the basics of the functional components of, how is that prescription impacting the visual vestibular interaction? So what's that going to do for dizziness? What's that going to do otherwise? Can you optimize it? How is that prescription impacting the quality of their binocular fusion when they're working on their computer? And, again, that systems part of me is like, well, those things actually aren't that hard to tease out if you can follow a simple system when you're running your exams and running through stuff. And so, I would love to see it where literally that's just kind of considered like standard of care. Because what's happening now is we give people glasses prescriptions. And here's the really nerdy engineering part is that every time you put a lens in front of somebody that's got any refractive power to it, plus or minus, we all know that that expands or contracts space. So you're magnifying or minifying. The magnification or minification, Trev, it changes how fast you see the world move when your head moves. So this is why so many of our people in contacts hate their glasses, etc., because we've got different magnification and minification. That has a direct impact on how the relationship between the eyes and inner ear. Because when you move your inner ear is telling you how much your head is moving and at what velocity, and your eyes are creating a reflex off of that. And the lenses we prescribe for people can impact that. And we're not taught about that, yet that is actually simple optics and, combined with neurology.
Yeah, and further to that, you could put a lens in front, a plus lens, and help you with reading clarity, but make yourself more what we call exophoric, and your eyes
Yeah.
separate more, and that is
Yeah, you might harm the binocular fusion.
yes, those relaxed lenses might be a negative in some ways without some other support mechanisms for that patient.
And I think that's, to me, from like that engineer brain, that's where we sort of miss out on stuff. We kind of go, okay, we're just it was like the study they did about myopia control and bifocals, and they just gave people random ads. You know, anybody would tell you that would fail. So, when you look at those parts, it's kind of going, okay, well, how do we measure what makes the system function the best? And utilize the tools at our disposal, whether that's the strength of the lens, multifocal lens designs, prism where applicable. People seem to forget that your lens actually has prism in it anytime you're looking off the center. And the question is, are you controlling for that or not? And so there's a whole bunch of other variables there.
Yeah, I always thought, Cam, myself, wouldn't vision therapy be part of myopia management? Is that something that you think makes sense, or am I off?
I'd say yes and no. So my work in New York with the Orthodox Jewish kids, and that's like the most myopic population in the world. Okay, these kids read for like 6 to 8 hours a day. And a lot of them common -9, -12, -13 and going up there. And what we came to find in our work down there is that we got the best results in reduction of myopia by providing the best binocular fusion at near. And it actually also coincided with the best studying and learning and focus and attention. And that's how my eyes are set up. You know, I'm about a +1 hyperope. I can walk around happy all day long with no glasses on. I just turned 40 like a few weeks ago, but like I'm happy all day long, no glasses on. However, when I sit and read and sit and study or do a lot of screen time or I'm in the office doing that, my lenses are designed to give me the best quality binocular fusion while I'm doing those things, and the difference in how I feel is tremendous. So, I think some of those concepts within myopia management are really important, but also within myopia management, so many of those kids you see, they may have a convergence issue. And so what are they doing? They're harnessing extra accommodation to try to stimulate convergence through the accommodative mechanism. That's a big one. Some of those kids have convergence excess. And so what are they doing? They're making the eye more myopic so they don't have to accommodate as much, which then means less convergence excess while they're doing their near work. So I think in the true myopia management spirit, like absolutely we should be looking at the whole picture.
I think, and that's really not stated so much, in my opinion. I don't think a lot of it's siloed again. It's all these silos.
I guarantee you, the second somebody has a patented approach to myopia management that can be sold for more than whatever, we will see that.
Yeah, I've always thought, like, intuitively, I've always thought we needed that. We don't have the expertise. Joe Average,
Yeah.
Trevor Miranda, optometrist,
Yeah.
doesn't have the expertise on that.
That's again one of the things that's a part of my career that's really important to me is I want to figure out, and I'm working on it now too, and some stuff we can talk about at a later date, but how do we put this stuff in the hands of optometrists where they don't need to have a vision therapy clinic? They don't need to invest in all this stuff. And quite frankly, training vision therapists and dealing with the more in-depth stuff, like it's time consuming and it's a big burden on an office. But how do we help empower optometrists with enough to really make a difference for people within their own career? So that's something I'm glad you hit on it. That's a very important thing for our profession.
Yeah, because we're going to basically prescribe glasses, but could we prescribe prism and other aspects of those glasses to optimize based on the individual? As you said before, it's individualized. So that also kind of protects our profession from, commoditizing lenses, because I think we could individualize, customize them based on people's binocularity or lack thereof. And I think that's a really great opportunity as we go forward. So I'm excited. We'll have to have you back because I'm sure you got some cool things cooking on that front. I wanted to talk to you a little bit about collaborating with other subspecialists in concussion care. So how do you manage that? As you said before, you've got neurophysiology, neurophysiotherapists, you've got chiropractors. How do you manage all of that when there's so many healthcare practitioners involved in this space?
So when we look at it, our approach really is, I mean, what we deal with is the visual components of whatever's going on. A lot of these patients may also have some vestibular stuff, some neck issues, whatever else. But our job is to make sure that their visual system's properly supported. And what we found is that if you can get the patient into the right lenses or that support the recovery and or at least making sure that their current glasses prescription isn't impairing their recovery, the other professionals' work also goes a lot faster. And that's even without adding any vision therapy components to it, because a lot of their stuff has some of the basic visual stuff in it, not some of the higher level stuff around, stereopsis and fusional vergence ranges and other components there. Um, so that's where we found it fits in really well, is they'll be kind of the more primary go-to sort of quote unquote concussion person, and dealing with that overall picture. And we get to make sure the visual system's properly supported so that the rest of their care is more effective. Because when you talk about neck things, so, and I had a woman like this the other day, if somebody's vision is uncomfortable when they move their head, so the visual vestibular interaction, etc., they will guard their neck more in order to prevent head movement. The other thing is if you have unstable fusion when you're sitting working at your computer or doing something else, unconsciously you will shift your head backwards and forwards a bit, often flexing everything in your subocciput area too. And we've seen that when we've collaborated with the other professionals. So optometry has a key role to play there. Should optometry start to become more educated on the subject and be able to assist?
Yeah, what do you think gets missed mostly with post concussion? Like, how are practitioners out there identifying that?
Subtle binocular vision issues. Those are the post-concussion patients are the ones where you may not measure a full CI. This could be a person who's literally plus a quarter, plus 50 OU, and there's something wrong with their vision. They struggle with screens, they struggle with reading, but they're like 27 years old. So, nobody's thinking about any of the accommodative or binocular quality. We've come to term it as is the quality of binocular fusion, like the stability and quality of binocular fusion. Because if they have an accommodative issue or a binocular issue, literally you're going to watch their two eyes not maintain quality fusion over time and or lose accuracy under conditions like saccades and head movement. And those are the cases that get missed.
And I've found, I don't know what you think about this, but for me, I sometimes hold up, loose prism to help see if that makes a difference subjectively. And sometimes immediately, some of those big home runs, they notice an improvement. Like they feel immediate relief, which then that they're a good candidate for interventions.
And well, think of it this way. I mean, your brain has the formulas in it that process your depth and space and then control your eye movements. If the ratio to which their formula is out is that half a diopter or one diopter, a prism, or whatever it is, and that's like you plugging just the right number into the math equation, then all of a sudden everything else goes click, 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 and falls into place. Now all of a sudden their eyes move accurately, their vestibular system works accurately. And so those are some of the coolest cases is when you get that opportunity to provide that click for the person. Now, what you can often achieve with vision therapy too is more flexibility and accuracy within the system. And then you'll find patients, do they appreciate those kind of changes? Yes. But are they as symptomatic and as sensitive to the change? Not as much, because their system can do more on its own in terms of flexibility, but they will still notice it over time.
Yeah, and I know in your book, Optimize, you share a story, James's story, a logger whose concussion symptoms weren't obvious and weren't acknowledged by insurers. And just like you say, it could be a subtle, small change. So how common is that, where they're very hidden, these symptoms, and then can you get them coverage for some of these therapies?
I'd say the symptoms aren't usually hidden, but the maybe the tests, and that's the problem. They'll see neuro-ophthalmology and they'll basically be like, okay, they're moderately farsighted with no major deviation, they should be fine. Because their criteria for a problem comes down to the size of the angle and whether or not the person's getting diplopia. Now, mind you, I could take you or any one of our listeners and make you incredibly uncomfortable and symptomatic without causing you diplopia or having to have a large angle just by adjusting your prescription in the wrong way. And we've all had those patients come back to our chair when that's happened to them.
It's so true. It's so true. We almost pushed them. We've pushed them into that symptomology, right?
Oh yeah, you can induce it accidentally.
Mm-hmm.
And so, that is one of the issues. And so that just creates headaches for insurers a lot of the time too, because they're like, well, who do we believe? Do we believe, our MD and our neuro-ophthalmologist on, they're saying there's no problems and we're saying there are issues. And really it comes down to like who's done what testing and who looks at what and who believes there's a problem. And it's extra frustrating for the patient because most of the time, those are the ones that, like you said, you've popped a change in prescription on and they're like, I feel way better. And meanwhile, they're basically being gaslit, being told that they actually don't have a problem.
Yeah, it's true. And I know sometimes even non-adapts patients that have purchased glasses, sometimes they're high end, premium lenses, and they don't love them. They just don't seem to, quote unquote, see through them well enough. And you're trying to figure out why these are the best, quote unquote, lenses in the marketplace at the time. And often that's a binocular vision dysfunction based on the fact that the prescription has pushed them potentially more exophoric at near and allowing, not allowing them to fuse in the near zone. So what are your thoughts about that?
I mean, Trevor, it also could have been what lenses did they have beforehand? If somebody's had a lens with particular prism thinning and their systems adapted to that, this is where that old sort of rule of thumb of like use the same lens design they've used before and have been happy in, and you're more likely to be successful. Well, some labs prism thin with base up, some prism thin with base down, some this way, that way, the next way. And so, sometimes you have to consider what has that person been habituated to? You could also have somebody where, they've got an amblyopic eye, yet they're habituated to that eye being uncorrected.
Yeah.
And
Yeah.
a lot of non-adapts can come because of the changes we're making in how they perceive stuff, which is not just your prescription, but it's also how are the glasses translated from your prescription to the glasses that they wear.
Yeah. And are you really particular with the designs that you use for particular patients?
Yes and no. I mean, very much over like certain things, like pretty like kind of anal retentive around, this is what this thing needs to be. It's like no, it's not acceptable if you increase the ad by a half just because, to fit them into something else.
Right. You have specifications based on their convergence needs.
Well, and also look at it this way. If you if you've got the optimal thing for a person at a certain working distance or whatever else, and in that lens design that they're wearing, it's not working for them, the answer isn't necessarily at like, it used to be like, oh, they can't see well enough through their reading area at close. So like, let's put them in a 3 ad. Okay, well, that's great if they actually hold it at 30 centimeters. But if they're not holding it at 30 centimeters, your problem is your lens design, not the amount of ad that you've put into it.
Right. Right. And I think that's super important. It's really sometimes we should do, testing after they get their glasses to see what the problem is on a BV basis.
You'd be amazed at that actually, and that's been a big learning for me is going looking at people who've non-adapted to glasses and then actually looking at what's gone on with their glasses and how their eyes are responding to it. When you mentioned some of those lenses with the low plus in the bottom, there's a number of companies making those out there where the where the ad is in the bottom of the lens is so low down, it's not even useful. And that's great because you're going to get zero non-adapts because guess what? It feels like a single vision because it basically is, except for the cost.
Yeah, interesting, interesting. I mean, I know if you had a plano lens and you help them with their convergence issues, rather than giving them an ad, sometimes that goes a lot further in terms of practicality for the
Yeah,
patient.
and depends what the underlying issue is.
Yeah,
You'd kind of treat it as the individual case.
yeah. I want to talk a little bit about erg optics.
The idea behind that way back when was ergoptics, and it was kind of looking at like how do we make a term that's about like ergonomic optics. Whether we end up doing anything with that or not later on, we'll see. But it's really it was a term at the time we were looking at to try to encompass how do we differentiate prescribing glasses not just for clarity but for optimal function. So rather than just here's your to quote sort of some of the older guys I worked with too, here's your 7 and 4 and out the door, versus okay, here's a prescription that's optimized for your binocular function at distance. Here's one that's optimized for what's happening when you're on your computer and reading, and sort of it's a different way of looking at prescribing and then even dispensing.
I think this is just a huge topic, really, that is just so it's misunderstood. We just
Well,
don't dive in enough in this area. I think it's really good. Just curiously, do you prescribe exercises for all your glasses wearers, or is something? Would you just like blinking exercises for dry eye patients sometimes can be very helpful, like to focus
yeah.
people to fully close their eyes, or if they're what we call leg ophthalmic and they don't close their eyes fully. Could you give patients an idea that these are some exercises that you could try at home?
I mean, you probably could. I think your challenge there is probably, you know, you're going to have a small amount of the percentage of people who are going to necessarily see benefit from it if it's not entirely what they need, which can then sort of sometimes take away from the credibility of doing those kind of things. Because it's like, well, yeah, I sort of did that and I didn't notice anything. Because if all those systems work fine for that person, it doesn't really matter. One thing when it does come to the dispensing in glasses and lenses that I think is important for a lot of the optometrists listening is when I first opened my office, Trev, doing vision therapy. I had no glasses and lenses, and simply due to some of the places that I had worked in the past where things were almost like really pushed and centered that way. And it was almost like, as an optometrist, I almost felt like it was a bit almost like dirty in a way. And this was around the time of online sales and stuff like that. So it's like I wanted to be out of the retail eyewear thing like completely. I was like, no way. Just didn't want to deal with it. And even patients' perception of things and my own perception. What totally changed it for me, though, was a number of my patients who were not successful within treatment. And once I realized how important the lenses were within treatment, and then I was spending half of my time phoning and arguing with opticals about how they had not been precise enough in the prescription. They'd given the patient different lens designs, they'd changed things up completely. And then, the person wasn't getting the results they needed because of that. And so I think we need to make a shift within optometry to actually, but it's sort of twofold. One, to understand how important the entire dispensing, lens selection, and every other part of that is. But that also means places need to hire and train people properly. But we really do need to see that as an integral part of making sure patients get the results that we want them to get. And it completely changes the mentality around that because all of a sudden, for me, being able to provide them with that was actually making sure that they got the care that they need. And in a way, I was protecting my patients and making sure that, they were treated properly.
Yeah, that's 100% makes sense to me. It really does. I think, just a question, how many of your patients need just exercises or exercises plus glasses? Can you kind of break that down percentage wise to me?
I'd say almost none get just exercises. We live in a modern world where our visual system's not made for the demands of our modern life. We haven't evolved to stare at screens. We haven't evolved to stare at iPhones. We haven't even evolved to read. And so, a lot of us have visual issues due to those things that may impact us at distance. But also, there's a huge component where a lot of problems start because of the things people are doing up close. And you can do the most wonderful vision therapy in the world with people, but if you don't deal with where their problems are arising from because of what the stress they put on their eyes and the strain, it's going to be largely ineffective. So I'd say it's almost the other way around. I'd say the majority of our patients just get glasses and lenses adjusted, and some of them also end up requiring vision therapy if neurologically they can't perform some of the things they need to, even with the right support.
Yeah, because they need the supportive glasses often for the prescription, and therefore it makes it easier, more practical to give them glasses that are adjusted with prism and such to help their muscle misalignment. Right. Wanted to get your thoughts on the trigeminal nerve. Like, I'm a dry eye specialist, and as you know, the trigeminal nerve is one of the big cranial nerves that innervates our jaw, innervates our cornea, goes to the neck region around our head. And I've seen a lot of dry eye symptoms where the patient is so complaining about their eyes, in sort of symptoms like dry eye, but there's no overt dryness on their cornea. And we've given them vision therapy or glasses that have helped with that immensely. What are your thoughts about that sort of referred pain piece with the trigeminal nerve?
So I it's interesting to hear you say that because I will get a lot of people with a lot of pain around the eye in general too. And I don't know completely whether that's related to the trigeminal nerve or sometimes whether that's extraocular muscle related because the person has unstable fixation and fusion. And so their brain is like, it's like, think about the wheels on a 1975 bus driving down the highway. You're fighting the whole time just to keep the thing aligned. You're gonna have sore arms versus you hop in a nice BMW now and it's like just like you hardly have to touch it or your Tesla and you're like, all right, we're going straight. And so we will see dry eye-ish issues sometimes from like poor blink rates and other things as people are trying to fixate and having issues there. But then I also believe that when you have really poor quality binocular fusion, the constant realignment effort can also cause a lot of those types of symptoms too. And that's probably where you've seen the results in using the lenses and vision therapy and helping with those symptoms.
I really have. I mean, I actually think if you have a dry eye clinic, you need a VT type workup before you come in because there's a certain subset of patients that could really help their binocular vision would really reduce their dry eye symptoms because they actually don't have dry eye. They have vision therapy disorders, binocular vision disorders that result in the feeling of dry eye.
And entirely, and it's that old adage, you're entitled to have more than one problem. Now, if you want to hear something, here's something really funny. So I used to think that I just ran a binocular vision office, and I've had about four patients who are monocular in the last number of years. And at first, I swear to you, the first one sat down and I'm like, well, this feels like it's going to be a waste of an appointment because you only have one eye. Like, what am I going to do for your binocular vision? But Trev, what I learned very quickly with her though was that, her vestibular visual, like the reflex ratio for the VOR gain or the vestibular ocular reflex was out. So the right amount of a little bit of prism massively helped her dizziness. Also,
Wow.
when we think of things like making saccades, before your eye makes the saccade, your brain has to judge how far does it go. So it's like, Trev, if I tell you to go 10 kilometers down the road on the map, if that's the right spot, fantastic. If I've misjudged the distance, but you go where I told you, you're going to the wrong spot. Okay. Or if I have the distance right, but you can't make judge the distance right when you move. So if the motor control's wrong, that you're also in the wrong spot. Now, that doesn't matter whether you're binocular or monocular. And
Hmm.
that's also why a lot of the problems with visual function don't simply disappear when a person covers one eye.
That's fascinating. That really is fascinating. What are your thoughts in monovision? If we're talking about monocular patients, putting somebody to be monovisioned with contact lenses, for instance. I'm not a big fan of that. I like to
Yeah.
promote binocularity
Yeah.
as much as possible. Are there longer term ramifications of putting somebody monovision? And for those listeners that don't understand it, it's one eye for distance and one eye for near. So we're dissociating your eye and brain to some degree. What are your thoughts?
I can think of several people in the world I don't like enough that I would put them in monovision.
Yeah, exactly. So you don't love it.
My friend's mom was dizzy and falling to the point where they're going to have to put her in a home. Okay. She'd been through all the testing, MRIs, ENT, everything. All right. She'd had monovision about 12 years prior, and her dizziness issues had gradually gotten worse. The human brain is made to have both eyes in focus at the same place in the same point in space. It is considered malpractice if we leave a kid anisometropic. And so
That
your
that's
brain
yeah.
is made to have both eyes in depth at the same time. The problem with monovision is that the binocularity decreases over time. So it's like a boiled fish, or sorry, boiled frog. So it's basically like a boiled frog because the person doesn't realize all of their issues creeping up. And sometimes it's like, okay, well, I'm just older now. I just can't concentrate as well. Don't all old people feel dizzy or miss steps or those kind of things? So personally, is there a time and place for monovision? For sure. Like I have a patient the other day where naturally she suppresses one eye all of the time. We don't want to break her suppression. Monovision works well. I have a friend who's an actor. Monovision works well for him sometimes because there are times when he can't wear glasses or lenses. He does need to see near and far. And you know what? To him, the payday is worth the headache and the bit of dizziness he has at the end of it. So there's pros and cons to all of those things, and that again comes down to how you treat the person as the individual and educate them on the pros and cons. But every person, this is especially important after head injury. The amount of people I see who are left in multifocal and monovision lenses after head injury, and it is one of the main things impeding their recovery, is huge.
I totally agree. If you're listening and you're an optometrist and you're fitting contact lenses, promote binocularity, including in multifocals, promote binocularity. I want to go to practical takeaways. So if a clinician wants to improve their concussion care tomorrow, what are some practical steps you'd recommend?
I mean, get to know the other local experts in concussion care in your area. Chances are you're also not going to be front line, and really pay attention to the binocular vision of those patients. Get informed, take some of the courses, learn how to prescribe properly for those patients, learn how to pay attention to what their binocular fusion is doing. And a lot of those people will be way more sensitive to previous issues that may have been there, but they may not be as sensitive to. And worst case scenario, if that person's having symptoms related to vision and you can't find a problem, say, I can't find a problem, not there is no problem. And I think that's an issue in medicine in general. Like for me, it's like, I can't find a problem, not there is no problem.
I like that.
Because obviously there is if the person's having symptoms.
What do you think the single biggest mistake ODs make when managing post concussion patients?
I think it's just that is telling them there's no issue sometimes. Or not digging deeper. Like, okay, so light sensitivity, vision issue. Headaches and migraines, often caused by vision. There's a great little test you can do called pattern glare. It's high contrast black and white lines. If the person looks at that and it bothers them, then you know their vision is part of the problem. That's like giving someone a peanut and seeing if they swell up. Like, that's part of the problem. Fogginess can be caused by vision. Problems with busy places, fatigue, trouble reading, trouble concentrating. If that post-concussion patient is having any of those, and if you can't find the issue, find the OD in your area who loves dealing with that stuff and get them off to them.
And I think some of these diagnostic tests, even if you're not managing that patient, just identifying that. So we'll put that in the show notes, some of your recommendations there, just to have those tests.
Pattern glare is like the easiest too. Like literally, you show them the black and white lines on the screen, and you're like, "Does this bother you?" And if it does, you know their vision's a part of the trigger.
I love that. That's a huge takeaway. We'll definitely put that in our show notes. So
And actually, for the ODs who get competent with this, that's one of your best referral sources ever, because you hand that like I send that to GPs, I send that to everybody, and I'm like, look, if your patient's having headaches or migraines or dizziness, and you want to know if their vision's part of the problem, show them these lines. If it bothers them, we know their vision's part of the problem. Now, some research I'm involved in too is that, Trev, if we hook someone up to an EEG and watch how their brain processes that image, and then we change their lenses in a way that supports their binocular fusion better, they see an objective change to the symptoms, but you also watch an objective change on the EEG.
that's fascinating. That's so cool. That's awesome. Okay, I want to pivot to one of our most popular segments, and this is Better One or Better Two. And as you know, Cam, sometimes it's too close to tell, right? So, Better One, writing a best-selling book, or Better Two, deliver a TED Talk watched by 1 million people.
TED Talk, because we got to rickroll the audience, and I think we were the first for that too. So,
And you've done TED Talks, right?
yeah.
Amazing. Better One, a month of hiking new trails every day, or Better Two, a month of exploring a new city every day.
Oh, that'd be a challenge. I go city. I'm a classic extrovert. Like, love trails, love that stuff. You know, want to see some people.
I think that's cool too. I would probably get lost on the new trail every day. I need to take the same trail just so I don't get lost. For some reason, I'll find my way around the city eventually. Somebody will tell me where to go. So, okay, Better One. Which superpower would you rather have? Number one, X-ray vision, or number two, mind reading?
Oh, I'd definitely go with mind reading. There's way more you could do in the world with that, I think.
Yeah, I mean, X-ray vision seems a little creepy and scary to me. I'm not sure I'd even want that.
Yeah, as long as you can turn it off sometimes too.
That's right, exactly.
Although I'd want to turn that off sometimes too. There's a lot of minds I do not want to read.
100%. Do you really want to know what everybody's thinking?
Yeah, might be humbling.
It would be really humbling. You know what I've noticed? You know, we have a student intern working with us, and he's great and learning lots. Is just that intuition, that responsiveness to how people are taking what you're saying, right? Being able to pivot and being able to dig deep and asking them questions to kind of uncover if there's some anxiety there, or they don't trust what you're saying, or making sure there's clarity in the education to each patient. I think that's sometimes missing in the next generation because they haven't been doing that.
Trev, I think it's huge, and maybe missing the next generation sometimes because of the forms of communication that are taken. At the end of the day, too, it's also not really trained to us in school either. And I think that I'm so glad you hit on that, because I think it's such an important thing, is that most of the time when we're talking to people, and this includes us as optometrists, we're thinking about what we're saying next. We're thinking about what we're doing. And there's often very little of focus and attention being put on the other person. And for somebody like that intern, I remember the amount that my life changed clinically when all of a sudden my awareness level started to actually be with the person that I'm communicating with. And then you feel like you can read them, you've got the pulse on things, you can tell when things are landing, when they're not, you're there with them. And it's such a difference than that disconnected feeling of sort of talking at somebody about something. And, and part of that even comes to understanding what their needs were in the first place. So you're speaking their language and about the things that they care about. But you're totally right. The presence. And I think some of that comes down to mindfulness. Are we busy in our own monkey brain and can't see past that? Or can we put our attention outside of us and onto the other person and be aware of that while we're communicating what we need to?
And that can be trained. Like if you're a younger OD, you can learn how to improve this. I always say optometry made me a better poker player, because I can learn and feel what's going on, what their senses are. And I'm a reader. I'm a reader of the players. So I read tendencies, and that's how it makes me a better poker player. So, okay, still better one, energy drinks, or better two, coffee every day.
I go coffee, less artificial sweeteners.
Even though you were an energy drink rep once upon a time.
I was in high school or in at university. Man, I love the fact that you've got this dirt on me for this. It's perfect.
Yeah, I do my research too, pal. So that's good.
You know what? There's if there's one thing nobody's ever said to me, it's that Cam needs more energy.
I'm the same way. I
Yeah.
mean,
Well, you are the same way. I mean, you're on fire too all the time. So
yeah, people are like, "What are you taking?" I'm like,
you're like oxygen.
"Yeah, yeah, I'm just breathing. I'm high on life for sure." Yeah. Spend the day working only with hyper kids or grumpy adults.
Boo. That's a hard one because it's like grumpy adults are fun to turn around, and you often can if you can figure it out. You can usually find a way to turn it around. Um, I probably see a level of hyper kids sometimes that other people don't see, and so I would go grumpy adults over the hyper kids that you can't even communicate with.
I'm the same way. I think let's turn the grumpy guy around. That's almost like a challenge that you could change him around. The hyper kids, I'm not sure. I'm just trying to get past that eye exam, to be honest.
Yeah, yeah, exactly.
Okay, I want to talk a little bit about your own in-house platform, Cameron. It's neurovisualtrainer.com. It helps people do VT exercises at home. Tell me about why you built this in the first place. What need were you trying to meet?
We weren't happy with the platforms that were out there, you know. So there's certain things that it kind of came from a few places. There's certain visual activities that do very well on a computer screen. Certain things around fusional vergence ranges and some other stuff, and even some things to do with like reading and some visual processing stuff can work very well on a computer screen. And so, but then I also had a lot of patient requests for some video demonstrations of exercises. So, whether it's a family where parents are co-parenting or other scenarios where it's helpful to have a refresher. So the platform was essentially created and then launched for free to ODs during COVID. And then we had to start, charging a per patient basis after that to be able to help deliver those activities and the videos and everything to the patients for the clinics. And so that was a little bit of a side project and been lots of good learning.
Yeah, that sounds amazing. I'm really interested in that. How do you educate patients and the families? Because a lot of times you're dealing with kids. How do you manage that interaction about the value of vision therapy and the services you offer?
A lot of it's going to come down to their priorities and their values. I think usually the first one is, if somebody's there and they're concerned about their kids reading, and if it turns out that that kid has tracking and other issues that are interfering with the reading, then the value part a lot of the time is in educating the parent and or demonstrating to them how much vision is involved in reading and those other tools there. So there's various different devices you can use to measure eye movement so you can show parents, because you as the OD might be sitting there going, well, I know it's a problem, but the question is how do you communicate that to the parent? And that's a big thing too. So that's often the big part of it. And also I think another key part is like not pressuring people about it either. And kind of running through that way. I think we're fortunate in the sense that when people Google us and they look at the reviews and like run through that stuff, like there's lots of social proof too. So yeah.
Yeah, and I think that read analyzer, that's one of the tests I think I remember you showing me of how it shows someone's actually reading and how they could be corrected. You've really demonstrated that well.
Yeah, yeah. So the Readalizer is great. That's one way of showing it. There's other products like Right Eye and things like that too. The challenge is, like any other test, nothing's the be all end all. You can have patients who are incredibly symptomatic and have a lot of vision issues, yet their right eye looks perfect, or whatever else. So it's always important too that clinicians don't become just centered around one technology measurement either.
Yeah, that's interesting. What excites you most about the future of VT and concussion care?
I think honestly, what excites me the most is I think with a very pragmatic, logical approach to the vision therapy side, I think there's the opportunity for way greater adoption of things and done in ways that really resonate with a lot of ODs who may even be practicing primary care and want to, maybe they don't want to do full VT, but they want to deal with the proper glasses and lenses side of it. Maybe they don't want to do full-blown VT in their office, but they want to have patients accessible to do, more of a self-paced home care program for it. And I think those are the things that really kind of excite me about that is seeing greater adoption. I think part of the problems has been is that VTs often lived in the world of the woo woo and sort of explained that way, at least as it was to me. And, for me, what my goal in my career is I would like to be part of bringing it to the docs en masse in ways that are easy to practice, work well into primary care. Like Trev, I see patients for 40 minutes for an initial exam. They've got 20 minutes of pre-testing. You don't need a 3 hour long BV workup to see people. The docs who I have who do primary care with me, their primary care exam includes all of the same binocular vision, functional vision testing that mine does, and they spend 40 minutes with a new patient going through that.
Yeah, you're one of the leaders in this space because you were someone that was doing BV and opened a. I remember when you opened this big vision therapy clinic all on your own, and I said, "Wow, that's ambitious." To kind of create this area of care that's never been there before. But now there's a lot of vision therapy.
Well, and we sort of pivoted a bit too, because at a point in time we were doing a ton of post-concussion work, and we had decent insurance coverage for some of that too, and that really changed here in BC too. So at one point, all of a sudden, it became okay. Well, you know, because people kept asking us, well, can you do our primary care as well? And like again, quite frankly, I don't like to do it. It's like what you said, it's hard to be the expert in a bunch of areas. And not that I'm proclaiming to be the expert in my area, but I've spent so long thinking about this stuff and obsessing over it that like I don't even want to think about classifying retinal disease or dealing with that. Like it's just so far out of my head now. Um, so yeah, and we've kind of flipped it around to now going, okay, we do primary care, but our primary care involves this stuff at every exam. So everybody's prescription is informed by their binocular vision. Everybody's stuff is informed by that. And guess what, Trev? If you get in a car accident in a year from now, we've got your tracking assessment from last year. We can see what's changed because of that.
Yeah, 100%. What would you say new ODs or younger ODs out there that want to improve their skills in vision therapy? What should they prepare for? What are some easy things they could do?
Um, I got my start, like I went through some of the OEP courses, the COVD courses, the SANIC courses. I'm like, I probably spent way too much money that I'm comfortable sharing on here, and a lot of time. That was at a time when I didn't have a family. I could travel for, courses for 5 or 6 weeks of the year at least. But a lot of our stuff was then also developed in house. So for them, it's like start brushing up on some of the courses out there. A couple of my colleagues, like Angela Petal and V2, they've got a great course on doing some lens prescribing basics, things to kind of get people going and thinking about it that way, and then they can sort of dig deeper from there.
Yeah. Well, as we wrap up here, Cam, I just want to say thank you for all you do for the profession. I don't think a lot of people realize when you're starting out, it's kind of like with me and dry eye, opened a dry eye clinic and there was like, what are you actually doing here? And then you realize there's a huge need. We can help a lot of patients. We can change lives. And you've done that with vision therapy, concussion recovery, rehab. And I'd like to see you out there more explaining what you do and how we can help support the community so we can have a bigger yield, if you will, at helping more of our patients that are suffering out there. So you're going to be one of the leaders as we go forward, that you already are, of course. So thank you for that.
Thanks, Trev. I mean, that's the goal. How do we bring better standards of care for these things and also make it not so intimidating for ODs to get into? I think there's a way to utilize this model that really makes everybody win. Patients get better results, less symptoms. For ODs, it differentiates them from the chains that are out there, et cetera. And it results in, better overall sales for the clinic, but sales in the most ethical way. All of our glasses, when we do things, for example, it's all satisfaction guaranteed. It's like, Trev, if these don't help you with your headaches or migraines, bring them back to me. I'll change them at no cost or I'll give you a refund. So, you're not selling somebody something, you're convincing somebody to do something that's good for them. So, that is my goal. How do we get this model of care out to everybody? And that's what you're going to see coming up for me in the next little while.
Yeah, that's amazing. And I love that you guarantee success. I mean, there is no downside to
I'm not perfect. I'm wrong sometimes. I got to refund a couple people a year.
Yeah,
Like, don't get me wrong,
100%.
but that's where the learning
Well,
happens.
and that's still caring for that patient because you're trying your best to alleviate their symptoms. So I want to thank you, Cam, for taking the time out. I know you're a busy doctor, a young dad, and you got a great family there. And hey, listen, I wanna take you golfing, or I want to see you some more. So if you got time to come up island, if you ever give yourself a day off, let's get together.
I'd love to. That'd be fantastic. Thank you,
Yeah.
Trev.